So there's one flag in the ground. I just want to let people know that I asked our speakers to if they could address two questions. What needs to be in place, or what are the criteria for determining that a program or a kernel or a practice is effective and ready for dissemination? That's one of the questions that I asked people to talk about. And the second one was, I said, implementation science has taught us the importance and difficulty in getting fidelity and high-quality implementation. How do you measure implementation fidelity in your system or in your program or in your practice or in principles? So those are the two questions that people are addressing. Our next presenter is Amy Margholis, who's the director of the Division of Program Development and Operations in the Office of Adolescent Health. And she's the lead for the office's National Evidence-Based Teen Pregnancy Prevention Program. She's responsible for developing programmatic and policy guidance, monitoring program implementation, overseeing training and technical assistance for grantees, and communicating lessons learned and program successes. She has lots of other important jobs, but this is really a big job that she's doing. And I had the opportunities, as many of you may have, of hearing about the progress that they've made in their first 5 years of trying to implement tested evidence-based programs in replications around the country and do research on those to decide what goes on in the next iteration. Amy.
Thank you so much. We're really excited to be here. I'm representing a whole team of people, but we were thrilled to get the invitation, so thank you. I am going to talk to you today about the successes and results from our teen pregnancy prevention program. Our program is a two-tiered evidence initiative. The majority of our funding, about $70 million each year, is for the replication of evidence-based programs. For us, there is a systematic review that's conducted by the Department of Health and Human Services that identifies which programs meet the standards for rigor, and those are the programs that are eligible to be replicated through our grant funding. And then we have a smaller portion of funding, about $24 million a year, that's set aside for developing and testing new and innovative approaches. So realizing that the evidence isn't static and we do need to continue to test and develop new approaches. Our program is a competitive grant program, so we really are focused on reaching the communities with the greatest need and the most vulnerable youth within those communities. We were just started in 2010, so we're in our 6th year. We have 2 cohorts of grantees that we've been working with. The first cohort, which I'll primarily be talking about today, was funded from 2010 to 2015. We worked with 102 different organizations and served 500,000 youth across 39 states and DC with that cohort. And then moving forward, we just started working with a new cohort of grantees, 84 grantees in July of 2015 for another 5 years, who anticipate more than doubling our reach for the number of youth we served, 1.2 million youth over the next 5 years. And so shifting to really focus on the successes and our results from the first 5 years, like I said, our grantees served 500,000 youth across the country. Most of those youth were younger. We did have good diversity in terms of race and ethnicity. We trained a lot of facilitators, established a lot of new community partnerships, so the reach of the program was significant from our perspective. We collected a lot of data on implementation. So we're trying to implement evidence-based programs. We have a big focus on doing that well and doing that with fidelity. We do, to the earlier conversation, we do have the same tension with adaptations. We allow minor adaptations and really work with grantees to kind of figure out what those adaptations are, what's allowable, but we discourage major adaptations. And so we collect uniform data from them. We know from our data 95% of all the sessions that were implemented as intended, which was our measure of fidelity, and 92% were implemented with quality. And that is data from independent observations. So we collect the data from the facilitators for all sessions, but we require that 10% of all sessions are observed by an independent observer who's been trained. And that's where our fidelity and quality data come from. We also know that the youth attendance was high, that on average, youth attended 86% of all sessions. We wanted to make sure not only was the program implemented well, but also that the youth were engaged and participating. And then we've had a big focus on dissemination. In addition to the number of youth we've served and our focus on implementation quality, we've invested significantly in evaluation. So this just shows you over the first 5 years of the program, in both our replication of evidence-based programs, which I'll probably slip in call Tier 1, and then our research and demonstration projects, across the two, we supported 41 different independent rigorous evaluations. And it was a mix of evaluations done through contract and evaluations done by grantees. I'm going to focus on our evaluations of evidence-based programs. In terms of evaluations of evidence-based programs, we had one contract that looked at evaluating 3 different evidence-based programs in 3 different sites each to see if we could sort of see differences across sites and then what we could pool data across the 3 sites. And then we had 16 different grantee-led evaluations. All of them were designed to meet the standards for a moderate or high rating for our evidence review, which is sort of the standard for being designated as an evidence-based program. We wanted any evaluation that we funded from our office to then be able to feed into the evidence review and generate a body of evidence. Across the contract and the grantee-led evaluation, we were able to test, it was 19 evaluations of 10 different evidence-based programs. And what we found at the end of the day, and it's also important that we were evaluating the evidence-based programs in new settings and with new populations. So not exactly where they were originally tested, really to try to broaden the body of evidence for the programs. We found that 4 of the 10 evidence-based programs that we evaluated were effective in new settings and with new populations. And we think that's really important, but we've been stressing that where we didn't see results, and we didn't see negative results, we just didn't see results, is more important in some ways, because we need to know where the programs are effective and where we're not seeing the same sorts of effectiveness, because that helps communities decide which programs are going to be the best fit for them. So we've learned a lot about where, when, and with whom programs are most effective through this work. Some of our lessons learned, I think I've heard a lot of this already, so it's not going to be news to anybody. But for us, the evidence review that identified which programs were considered evidence-based teen pregnancy prevention programs, most of those programs were backed by a single study. And so we really think that there needs to be a body of evidence for programs. We need to start with the evidence that we have, but we should continue to build on that body of evidence so we really can learn more about where, when, and with whom programs are most effective. We think that independent evaluations are really important, and we think what we're seeing is that maybe not all programs can be implemented anywhere and with anyone with the same results, that there might be some programs that are really generalizable and can be taken to scale everywhere, and then there are other programs which maybe are for more targeted settings and more targeted populations. And for us, it's important to have all of those programs in the mix for communities to be able to make decisions about what works best for them. Also, our evidence review, the time period is 20 years. That's a really long time, especially when it comes to adolescents, and so it's possible that programs that were effective at one point in time may no longer be effective at a later point in time. And so I think a single study, again, the evidence isn't static, so we feel like we really need to kind of keep doing evaluations and building the evidence. And then we've learned things that won't be a surprise to anybody here, but how programs are implemented affects outcomes, that dosage is really important, and that training technical assistance and using data to make decisions are really critical. One of our big lessons was that more time and emphasis needs to be spent on program selection. We have a list of 44 different evidence-based programs. Lots of them have been around for a long time. People are really comfortable with them. And so we found the reasons for selecting a program to implement in communities can be based on a variety of different things. Some just because you've already been trained in those, you've invested money in the supplies, but the decisions about which programs to implement need to be based on what's the need of the community and what's the best fit for the community, and that takes time. We've also seen and found that using evaluation results to inform program selection can be really difficult, and that sometimes it does mean moving away from programs you've always done, and that can be really hard for community groups, especially when they've been working on these things for a long, long time. So in addition to everything that we've found, we are really committed to using our data and using our evaluation to continue to improve the program as we move forward. So we have a big emphasis on working with our grantees. We collect a lot of data and making sure that it's not just data we collect for us at the federal level, but that we're training and working with them and coaching them on how to use that data to make program decisions for continuous quality improvement. We're doing that all the time. We also are using the evaluation results from our first cohort to inform selection of programs for our second cohort, and have spent a lot of time really trying to translate evidence for grantees and communities so that they can understand and build that into their selection process. We've used the lessons learned and the results from our first cohort to redesign the program to try to have the greatest impact possible. And then obviously we've identified areas that are in need of new and continued research. And I just wanted to focus on how we're using the evaluation results to inform selection with our second cohort of grantees. In just a couple of examples, but now we have this broader body of evidence. So originally it was very easy. There was a single study, so there weren't mixed findings for any one study. But now we have multiple studies for individual programs, and it can be really confusing. Anywhere where we found a negative result, and it was only 1 out of our 41 sites, but we're not allowing our new grantees moving forward to implement that program in the same way that had a negative. That was just a decision we made as a federal program office, that we were going to be conservative until the evidence showed us something different. And also for us, I mean, this is subjective, but we were looking for a body of evidence. So our body of evidence right now is 3 or more studies. And if there were 3 or more studies unable to replicate findings from the original study, we're taking that as a body of evidence, and we're working with grantees to see if there's a different program that might be a better fit with stronger evidence that they can implement in their community. If the evidence is 20 years old or more, it's being aged off. We need more current evidence. So 20 years is sort of our guide point for when sort of that is too old, without any newer evidence since then. We're allowing our grantees to implement new evidence-based programs as they're identified, and then we're really working to help grantees and communities understand what the evidence means. And I wanted to spend a minute just talking about that. It came up earlier this morning too, but the importance of translating evidence. We are finding that a lot of the times there's this list of 44 programs. A lot of folks think as long as they choose anything on that list, they're going to have the same, you know, it's all evidence-based, so it'll be the same outcomes, it's all good. And so our programs are incredibly diverse in terms of their focus, what the outcomes were, who the outcomes were for, how long the outcomes lasted. And so we've spent a lot of time really trying to help translate the evidence. I don't know if we've figured out, you know, what's most effective for everybody, but we have added more detailed information to implementation reports. We've done these, you know, easy at-a-glance charts where you can see differences right away in one place. We've done interviews with developers to try to get, you know, different non-written form of information out there. We've worked with grantees that have implemented the programs before to talk about sort of best practices and tips and adaptations that they've done and put that out there, but really trying to help folks understand the differences between programs so that they can make decisions based on fit. And then we have also used the lessons, like I said, to redesign our program moving forward. For our first cohort, we were really focused on implementing 1 or 2 evidence-based programs and doing it really well. And as we move forward, we're sort of moving away from a reliance on a single evidence-based program to, we think that adolescents need multiple evidence-based programs over the course of their adolescence. So something in middle school, something in high school, something when you go to the clinic, something in community. So we're talking about evidence-based programs in multiple settings and within a more holistic framework. So we now have a much bigger emphasis on community mobilization, collective impact, engaging youth and families, ensuring that environments are safe and supportive, and trauma-informed services, and linkages to healthcare. And then we still keep our focus on data and evaluation, dissemination, and sustainability to try to really have the greatest impact on preventing pregnancy and reducing disparities. Like I said, there's a team behind me, so thank you for the time. We really appreciate being able to get out and talk about what we did.